our progress towards validation. Today, for our session, the presentation will be by Dr. Ruth Masha. Dr. Ruth Masha is the head of NAC, working in that role. She has long-term experience with PMTCT, HIV/AIDS, has worked in many different places, including both the Nairobi and the Geneva UNAIDS offices before now coming to NAC. In those positions, she was very active in the space of EMTCT. She's a very engaging speaker, has a very deep understanding of the issues. I believe today will be a very enlightening presentation and also inspiring to inspire us to actually achieve this goal of elimination. So Ruth, my namesake, the floor is yours. I see we have about 400 participants already and numbers are climbing. I'm glad everybody is here. Thank you. So please go ahead and mute yourself and go ahead. And I hope we're able to project her presentation. Over to you, Dr. Karume. Have you heard me? Mumenisikia?
Yes, we can hear you, Professor.
So we are waiting and to the production, the presentation. Masha, can you hear us? Dr. Kinuki, I think you have a phone number. Do you want to call her and find out whether she can hear us? Okay, Dr. Duena, are you able to reach out to Dr. Masha?
Let me.
Yeah.
Agnes, can we project the slides?
Yes, we are trying to do that. We are getting a hitch up in the projection. I don't know why, but we are trying to do that. Yeah.
Okay, the slides are there now. Dr. Masha, please just go ahead. Thank you. Agnes, do you know what's the problem? We can see the slides now. But we can't hear Ruth.
No, I've spoken to that. So.
Okay. Agnes, you're having trouble with projection?
No, actually, we'd like the presentation sent to the KNH research at Gmail. I think she was projecting from her end. Dr. Masha, if you can forward to the KNH research at Gmail, then we'll be able to project.
Prof,
Yes?
can I request you to introduce Dr. Ruth again so she can start?
Pardon, what you said? Don't hear you.
I was asking whether you could introduce Dr. Ruth Masha so she can start.
Yes, I had actually introduced her. I'll do it
I know
again.
that, yes. Yes. Please.
Yes. Yes. So, Dr. Ruth Karibu. Dr. Ruth is the Chief Executive Officer at NAC. She's a public health specialist, has wide-ranging experience in HIV, human rights, gender, sexual and reproductive health. Has worked with UNAIDS. In fact, that's where I first met her, and UNAIDS in Kenya and in Geneva, and particularly focused on issues of elimination of mother-child transmission of HIV. She now gives very able leadership at NAC. So I also made the observation that she's a very engaging speaker, and I think we will enjoy and be inspired by her presentation today. So Ruth, please go ahead. We can now see the slide, the poster. I hope we can soon also see your slides as you present. Of course, for all of us, we know that our PMTCT agenda is actually work in progress and needing innovation and commitment. I know this forum has many physicians and specialists and senior people, senior nurses, pharmacists. Part of our challenge is that the people who are in who are more trained, who like your consultant pediatricians, OBGYNs and all that, I think around Kenya have been a bit hands off this PMTCT program. And I hope as you listen to the presentation, will challenge us, each other, to be a bit more engaged, to support our counties, our facilities, to really be able to achieve the goals of elimination. I think it's tragic that a child gets HIV infected today. Yeah, Ruth, are you ready? Are you able to present now?
Yes, Prof. Yeah, thank you very much. Yes, I'm.
Okay, Karibu, please go ahead.
Sorry, I have a cough, so I'll keep excusing myself.
That's fine, just go ahead. You can start.
So good afternoon, everyone, and apologies for that hitch, a little bit of a hitch. I just arrived from Trans Nzoia, where we have been talking about the triple threat, which is basically trying to remind us that HIV is still with us here today. So I'm glad that it's after that conversation and after meeting a couple of 10-year-olds, 13-year-olds who are HIV positive, as well as having children, that we actually been doing this presentation. So you can see the slide. So maybe I do the slide in the presentation. Would you be able to see the slide? Prof, are you able to see this?
We are. Yes, we are. And it is in presentation mode, it looks like.
It's not in a presentation mode yet?
It is.
Thank you. So let me just begin by saying that, of course, I am glad that we've convened this webinar at especially a very opportune moment. Prof, as you rightly said, we began this journey way back. And at that time, we were very sure that as a country, we were going to be able to eliminate new HIV infections among children. And we thought that at that point in around 2015, that will be at the same level with countries such as what you're seeing happening in Botswana. Sorry. Where we are comparing ourselves with the countries that have high burden. We've also seen that we were also at that point trying to see what our neighbors even here in Uganda were doing, and we were very optimistic that indeed by then 2020 we will have actually been inviting the WHO for a validation exercise, basically to say that the work was done. But unfortunately or fortunately, we have done a lot of work, and I want to take this opportunity to congratulate most of us who have been on this journey for a long time. But recently, as we began to pause of what you can do differently, I personally began questioning ourselves. Is it that we have not created enough social dialogue to actually remind people that HIV is still with us? Is it that we have actually taken for granted that what it takes to have a child born with HIV and take them through adolescence and adulthood and the challenges we face even just as a health sector alone? Or is it because that maybe we've got so many challenges that this challenge doesn't seem to be a challenge enough for all of us? So, you know, I then thought that if we quickly just have a glance of where we are within the epidemic, especially the metrics that we have, and so we always call these as estimates. If you look at our figures, of course, we keep saying we've done a lot. We say that we have done quite well in treatment coverage, especially for children. There's a time we're at 42%, pathetic figures there. And then 2013 and then 2020, we saw ourselves going up to 84. And of course, you look at the data for 2021, those figures have improved. We've also registered quite a number of significant progress, especially where deaths are related. And we've reduced the number of AIDS-related deaths. But then this is when we compare ourselves with ourselves, we keep seeing progress, and we've always been putting up our slides and we talk about we have done a lot of progress. Look at the AIDS-related deaths. By 2020, the last figure, we are talking about children between 0 to 14, around 3,000 children. We know that for the last 3 years, we've been talking about COVID-19, and we are saying that we've lost around 5,000, and we always find these figures very, very high. But if you look at the figures for children we are losing to AIDS, they are still significantly high. And therefore, we know that this job is not yet done. But on a nutshell, we have just been really celebrating the success. You can see even the number of infections from as high as 100,000 and around 32,000 this year. And we're talking about almost a 68% reduction. But when we look at a comparison with other countries, we were looking at where Kenya is currently placed, whereas this slide looks nice. If you compare Kenya, South Africa, and other countries, you find that we are still with the slide that we used to have for counties. We are at a working stage where basically that all our efforts have not really gone towards acceleration of progress. So what will it take us to actually get to where we want to reach? I think for me, what I'm beginning to learn is the conversation of prevention. A time has come where we need to normalize prevention. I think for a long time, when we started talking about stigma, we then mistook education for stigma, that we have normalized HIV. As I've gone around the country, what I'm keep hearing is that people telling me that, you know, wakati tulikuwa tunajua HIV ilikuwa kitu ngumu, but now HIV is like malaria. So when we start saying HIV is like malaria, then we begin to have a different conversation even with the people we serve, because then people start thinking that this is just a disease we can have for the rest of our life. So what will it then take us to begin thinking about what is happening in the country, where this discussion is happening, and who are we having the discussion with? First of all, is a reflection. even as a response itself, who have we been talking to? Maybe basically been talking to ourselves. Because when you go out there and you begin talking to people of really significant positions, we recently were talking to MCAs from, it was Nyeri County, and just a while back, and one of them told us, is HIV still there? Bado watoto wanazaliwa na HIV. I mean, those are the people who are very, very important to us, but they're still asking those questions that is this disease still there or it is over? So that prioritization really of who we need to prioritize prevention with is very, very important. Then of course, we really have geographies, and you're going to see in another slide, and locations and populations that we need to think differently about. We have been looking at some of the population, including like women who inject drugs, who are actually just increasing over time. And you realize this group is also very, very difficult to program with, and especially where mother-to-child transmission is concerned. Immediately we put these women under methadone program, the first thing they do is to become pregnant. Then again, we begin to have the pregnant women, the methadone babies, and those populations remain still unreached. We have, of course, the cohort of sex workers that we have been talking about in prevention, which we've very done as well as a country. But also, you sometimes forget these sex workers are also women with families, and we also need to take the conversation ahead around prevention. The other element is the biggest elephant in the room, which has been commodity security. And this is now where the rubber meets the road. As a country, we need to prioritize our testing. So we become...
Hii, hata ukilala unalala nayo. Unalala na kitabu na
something, prioritization of commodities. So we initially, when we started this EMTCT program, the one thing we were very sure of how we were going to win was that we needed diagnosis. Now diagnosis has been affected by commodities. Commodities are affected because we have been, we are now currently on a transition, and all of us know that we've been seeing this on the press, that we have to transition to buy the commodities by ourselves. And it's really been a huge, huge challenge, especially sitting from the position where I'm sitting, because then all of a sudden you begin to realize that as a country, even most of our policymakers did not even know the cost of doing business for this response. So if we don't give universal testing to every person who requires the diagnosis, then we begin to then shrink our capacity to even begin talking about a PMCT program. So that commodity security begins to become a very, very critical element of what we must look at if you have to get to zero. So of course, the World Health Organization criteria for validation, what they have given and what countries have done for them to be validated, has been having mother-to-child transmission rate of less than 2% or less than 5% in breastfeeding population, and a case rate of 50 per 100,000 live births. We actually know this as a country, it's very difficult to reach that because of the population. And then the process criteria has been coverage of ANC, which has been very good in Kenya, then testing coverage for women who are pregnant, and the ART coverage. And again, on the other side, as we do that for HIV, then we are required to do the same for syphilis. And one other criteria is that the impact must be met for more than 1 year, or that is the impact level, EMTCT, and then the process level must have been met for 2 years. So that has been really a tall order for Kenya, because one of the things we have realized in Kenya is our program lacks resilience. It depends. If Professor Rudy is sitting on the table today for 2 years consistently, we begin to see results. If we have technical teams realigned, we begin to see results are changing. So we lack, even at the technical level, we are lacking championship or resilience in terms of how we do things for consistency purpose, so that within a period of 2 years, the success can be replicated year and year. And that's what we see those countries such as Botswana and Cuba that have been validated were able to do. So look at us, how we have performed. So the 8.3% here was when we were dancing, and Prof and those people in the room, I mean in the call, they remember us dancing when we reached 8.3. And in our imagination was that was going to go straight to a reduction, and then we hope that by 2020 will be below 5%. So we moved quickly from 2015, 8.3%. to 11.5% transmission rate in 2017. I must admit, at this point, we didn't have an issue so much of commodities, because this time we were really, we had still a sufficient funding for commodities. So something is happening there. These 2 years, something is going wrong. It could be around programming, it could be around what Prof began by saying, that even ourselves in the medical, the health sector probably not serious enough, or we have dropped the ball. And we can see then the curve then beginning to go a little bit down, 10.8%. And again, in 2 years, we are not really making any significant progress. So if we were to go to 5% at this rate, that means that then we would then take probably almost until 2030 for us to reach there. So this is the biggest challenge we have. Now, this program depends a lot on a couple of issues. First, it requires us to be in sync with communities. Second, it requires us to be in sync, especially with the women living with HIV. And thirdly, it requires us to see who are these people, who are these who contributed this 9.7, where are they, which geographical location are they coming from? Because then unless we begin to say this story and dissect it to the lowest level, then our own pre-validation or validation process is going to be in vain. So that is the challenge that we're talking about today. And then the other challenge in the room is that, of course, now this disease, HIV, has primarily become a disease affecting women of childbearing age. So now this is the distribution of people living with HIV. So 15 to 49, majority of our people living with HIV are women. These are the women we are talking about. Then again, you see, we're also building the lower cohort of the children as they come up. Again, look at the population that we have, so that you see that what has changed from 2010 to what is happening in 2020. You can again see that the challenge of HIV still continue to coalesce around the same ages that we need to continue programming for. Now, this is where the problem has been. If you look at this map, of course, around that 1 counties missed the target we had of reducing new HIV infection. And then the other thing that they also missed was that we begin to observe an increase in HIV infection. So where you can see red, these are places where you have seen increase in HIV infections. Where you have seen green, a lot of effort has gone there. You have seen Homa Bay, Migori, around this area, where again, we have put a lot of effort, especially on treatment program, and you can see the green, but then the reds begin to add where we had not had reds before. And that is what we have a big challenge. So we have the Nyanza region reducing their new HIV infections among children, but then when you have the other counties now who may have very significant numbers, and we must admit that some of these counties like the northern, eastern, Marsabit, Mandera, Wajir, these counties here have very few numbers, but they've been increasing over time. So we probably moved to what we call location population. But as we move from Marsabit and these other areas where we're programming, and then the roads are opening, devolution money is going, there's flow of people from Marsabit to other counties, to Nairobi, in a day or two. And you can see the reds beginning to become more red. So that is one of the biggest challenges. Then of course, there's still missed opportunities in what we've been trying to do. If you look at the estimated number of pregnant women and how we actually have been programming the new NC clients, the initial testing, look at here 69%, that means around 31% of the women being missed, that is 2019. We have improved, but only for HIV testing. We now say we are missing around maybe that is 33%. But still, these people we are talking about, the missed people, that means that we have women probably are delivering, they've not tested for both HIV and syphilis, and therefore the only thing that we can begin to think is that for those women we are talking about, they're in the ages that we had before even we started the PNC program. So their chance, if we did it through what data is telling us, is almost 40% of infecting their children. So of course, we initially started talking about the prompts and talking about how we are going to improve. But if you look at those curves that we have here, the skill bar delivery, while we keep improving, the progress has really been, almost like a crawling progress, which we try to do, but we still keep on the same. So we are still high, but then we don't seem to have any accelerated action. So only 27 counties met 95% of fast EMTCT coverage, and you can see those 27 counties that have met that target. Other counties, these ones have met. Then you can see other counties that begin to miss those targets for just one indicator that is so important for this program, tenders of EMTCT. So where there's so much improvement over the years, you begin to see now this is program data, that counties that you don't expect to be here are already here. You can see Meru here. You probably don't expect to see Nyeri here. You may not probably be expecting to see Nyamira, Kisii, Kitui. Some of the counties that have fairly good infrastructure, you'd expect them to be on the green, but they are not. So, of course, again, as I said, 20% not being tested for HIV, which is really a significant number in some of those counties. So that's also a big challenge. Syphilis, we must admit this area also, we have not been looking at syphilis as an area where we also need to think about the both of them testing and coverage of treatment being in sync with the HIV. Sometimes we have been having challenges, including the challenges of data in this area, but then there's a conversation that you begin to ask, what is going on with this syphilis? What is going on in Nairobi County? Here you can see these are the people we have in the clients. But if you look at a county like Homa Bay, I know there's a study now going on in Homa Bay, and this story, this is just program data, but this story seems to be resonating with what people are finding out on the ground. Look at syphilis positivity rate, Homa Bay. So if indeed we are winning the war against HIV in Homa Bay, so what is happening with syphilis? So probably what we are seeing in Homa Bay County is that the viral load suppression is helping us with HIV, but people then are not using any protection as we think, because then that means that you probably are getting the benefit of treatment, but you're not getting the benefit of prevention that would have ought to be. So there's need for us to look at this program, because this is a serious indicator of the challenge of unprotected sex. So the more we still begin to see STIs increasing, I know the other counties that we could see here, Migori County, a similar story, and Nandi County. So those are some of the areas that we probably need to think about, because if you don't look at the burden then of STIs, just syphilis alone, it's also a point out chlamydia and gonorrhea and others that we also are not following up. So there's a lot of issues around STI. And then of course, ART, I know somebody else is going to probably be talking about this, but still we have around 3% of unmet need. Basically, we have not been able to cover those women. PMTT coverage, of course, the border counties tend to have a higher coverage because of serving people from other counties, so their denominator is higher, but you can see the coverage is very low in the country. Some of the counties began to see red. You see those counties that we left behind, the Maldera, Wajir, Baringo County, Kitui. And then again, you begin to see counties which you fairly think something is wrong. The Nyeri counties you're beginning to see here. Maybe a county like, I'd see some of these counties that have low coverage, and you begin to wonder what is actually happening in the program. So this could be as a result of other factors that are not necessarily just commodities. So our efforts have been very inconsistent, and that probably brings the question of why we keep having different results. So today we are doing well, tomorrow we are not doing fine, and that's basically our biggest challenge. So in essence, business as usual will not take us where we want to go. So no matter what we do, we are now currently looking at 2025, then it would be almost 2,500 if we continue doing what we're doing, children being born with HIV. I want to remind us that this actually is a huge number for any country. And we probably have been used to high figures, we've been used to big numbers, and therefore, when we see a number like 2,500, we tend to think it's really small. But if you even just begin putting these children in one room and imagine what 2,500 children will look like in 2025, we still begin to see those are too many children. So what is the issue? The one challenge we have seen, which you're going to see in data, is that actually we are trying to program the PMCT programs to children. Yesterday in Trans Nzoia, the children who are coming up, they've been called child mothers. So the ones who are coming up to talk to us about their issues, they are calling themselves STB survivors, carrying their babies. They're actually just children. So you ask yourself as a practitioner or as a scientific community, how will you start programming on PMCT with a child who is 12-year-old? How do you start this conversation? Because even the healing process of diagnosis of a baby, of school disruption is just too much mental anguish for this child. And you can see an overlay where we're having big bubbles of STI cases, of STB cases. You also have big bubbles of teenage pregnancy. Then again, you have a bubble of seeing the new infection, especially between 10 to 19. And what connects all this is a sexual encounter. Of course, it could be unwanted, unintended, but most importantly, it's unprotected for those girls. So, of course, this data we have been looking at, and we are seeing these more girls are contributing, are 42.5%, 4% across the country of all the STBV cases between 10 to 19. And then we're seeing ANC attendance. We are trying to program 20% being those children. And of course, you can look at the infections. This is something about teenage pregnancies, and you can see what is happening just in the month of January to May. This is a very important slide because we had expected that coming from as high as 400,000 teenage pregnancies in 2018, we were reducing, but then our reduction is really, really suboptimal. If you look at that data, it tells you something's wrong. And one of the things that I think is very, very important is looking at the percentage of those teen pregnancies in some of those counties. Look at Kakamega and Bugoma, the people we are programming just for this January to May. So this is a very serious issue. Again, STBV cases, you can see, these are the total STBV cases, and the bar shows you the contribution of 10 to 17. Basically, those children who have been either defiled or they are victim of STBV. So you find counties like Kilifi, of course, they have done a lot of work. Omabisia, where we have high epidemic, they're still also having quite a high number of STBV cases. This is basically the STBV cases over the years, just for us to have a reflection. And this is speaking just 10 to 17. You see 2016, we were getting about 42% of those cases have been for 10 to the percentage of 2004 being at 42% of all the STBV cases. But as you go down, again, we begin to see still on 2021, 16,000 of these cases were actually those children. So that is beginning to have a serious challenge. When you go across the counties, as the years go by, you look at the numbers where we're having a reverse gear. Basically, this could be probably because of awareness, people are reporting, but still, if you look at those counties, you begin to also see something is wrong, especially on teenage pregnancy. We went to Meru County and we went to one of the hospitals where we just met almost the whole world had, children. In fact, if there is a woman there who is 20 years, you're out of place. 22, you're a very old woman. The rest are all children around you giving birth. So this could be a story that of course, of increased reporting, but also a story that is actually going on the ground. And of course, there are these counties that have done well in terms of where they're going. You can see Kilifi County, over the years, they had large numbers of STB cases. They are also reducing, especially among children. So there's progress, but not enough. So why are we talking about these children, for example, in the context of PMCT? Because of course, sexual violence, in any case, if you have these mothers, we're programming around, most likely they will lack education. We need them to come for ANC. They are likely to be put into other vulnerabilities, including the increase of sexual violence just because they are teen mothers, and of course, becoming more vulnerable to also HIV if they do not have HIV. But most importantly is that we all know that the PMCT program has shown results over the years. We always estimate that we have averted almost 121,501 cases and saved the country a total of around 129.2 billion. This excludes the human resources, resource costs that we've been using. So we have a challenge, yes, and I think most importantly is a challenge that requires us to look at what are some of the issues that we are currently having. Allow me to just jump straight to service delivery limitation. the commodity shortage we talked about, the legal restriction. This is very big, and I see recently you saw us putting out a notice that we would require to requesting that the public start participating in the HIV Prevention Act. Basically, is to try to look at these restrictions now that have begun to affect the testing, especially at ANC. We have now, of course, a couple of nurses refusing to test, given the Mombasa case that has not yet been resolved. And if indeed we are not able to test through other cadres of medical fraternity and just think that we'll only test HIV in the laboratory, it takes us back almost 10 years ago, where we, actually more than 10 years ago, where this was happening. So some of those issues are happening. And then of course we have staff turnover and attrition, especially across counties. Our integration is very, very weak in terms of programming, in terms of our linkage with communities. That is a really big missing pointer. And then of course, data. If you can't be able to interpret the data and look at what we are doing, double reporting or under reporting, then validation is going to be miles away from us. So where do we see ourselves going? What is the solution? We are looking at leadership and coordination at the national and county level. This is a deal breaker. I always tell people that if you don't know the power of leadership and coordination, you just look at our data between 2015 to 2018, when we made significant progress. What were we doing? We knew what was going on across every county. We had the data, we cleaned up the data. Even when we missed opportunities, we went back across the country looking for those people. We were able to move from data, which is not identifying anyone, down to the community level, working with people living with HIV, working with mothers, mentor mothers, to actually get now to the people who are missing. So that's a very, very important one. Of course, the mobilization of resources, we need to begin thinking about both private and public sector. I know now that we'll never get the same money we have. We recently were trying to get just only the first line drug on the Exchequer Fund. But when you did the math, we needed around 8.4 billion just for TLD. And that is a drug, just buying the drug, buying it locally here, manufacturing it locally and getting it here. And that actually just, it does not require the Ministry of Health. It requires Ministry of Health, Treasury, and parliamentary, the two parliamentary committees, which means that we are talking about the expanding the physical space of the Ministry of Health at large, because you can't absorb, for example, an entire 8.4 billion in the current setup and the money that is allowed or the money that is allocated for the Ministry of Health. So it's a broader conversation about what shall we do to actually put the resources on the table. And then also for us, what one of the questions parliamentarians began to ask us is, for how long do you want to keep adding new infections? So if we sit there and expect to have more children being born with HIV and take them through all phases of life to adulthood, what does that mean for the country? And then of course, there's a level of stigma reduction and the involvement of families. This has always been mostly theoretical, especially when we are designing programs. I mean, talk about stigma, all of us, but then when it comes to programming, there's no systematic way in which we talk about how to reduce stigma for both women and also the girls living with HIV. Then of course the accountability mechanism, which is why we were talking about having validation teams and pre-validation teams so that we can be able to account. You've seen the power of accountability, you've seen the power of maternal audit that is happening across the country. You saw in Nairobi County, after they began putting a spotlight on Pumwani, that the deaths have significantly reduced, the maternal deaths. And of course, there are other things that have improved around there. But one of the areas that usually provide results immediately is that accountability mechanism and the multi-sector approaches that we are talking about. So I think we've had quite a number of strengths in the program, but it's basically for us to stand up and say, really, how will we be judged in history? Are you going to be judged as a generation that waited for a disease to get to another generation and another one? Because you can imagine my own grandchild coming back to camp and the one thing she meets is HIV again on the table. So I think we must really change ourselves and begin to think, how do we refocus and make sure this program is yielding results. And of course, there's those groups that we're talking about, the adolescents and the other groups that we have not targeted previously, but also the UHC agenda. When we are trying to look at the NHIF cover, I recently wondered, all these people in the HIV, if you're in partnership with them and begin to start seeing which are the women who are actually giving birth and they also do not have access to insurance, then probably we need to begin asking ourselves as a sector, how do we, without stigmatization, ensure that all, especially the non-positives, have been supported to deliver in a hospital, and then when they also have planned to have the pregnancy. So I think for us as National AIDS Control Council, we still believe validation is possible in this country, and we also believe that we can jointly be able to tackle this challenge if we look at ourselves and also reorganize how we do business. Thank you, and over to you, Prof.
Thank you very much, Ruth. As always, you present data that is very thought-provoking. And the talk now is open for questions. We'll look at that. You can send your questions to the chat box. And I can see already there's some here. It's good afternoon. Could the rising new HIV infections in children be related to continued breastfeeding in HIV-positive mothers? For mothers are advised in the MOH guideline, irrespective of viral load. Are there any studies on this? Next question is, many counties are not testing for HIV in ANC due to lack of kits. This was as late as last week in most counties. There was also low EID testing for the last 18 months. How can we have a reduction in EMTCT to 9.7%, yet there are so many missed opportunities? Then maybe Dr. Masha, 2 questions, and then I'll read the next one. Ruth, are you able to? Yes, please, go ahead.
From the before the commodity, there's another question, you didn't get it right.
Yes, the commodity, the first question before commodity was the rising new infections in children, are they related to continued breastfeeding in HIV-positive mothers? Since we advise the MOH guidelines is to continue breastfeeding regardless of the viral load.
Thank you, Prof. I don't think, and I know you're the prof of this subject, I don't think we say regardless of the viral load. So, but I think, and you can probably come in here with the science, because we are clear that indeed breastfeeding on treatment is a way to go, and of course not breastfeeding without treatment. And Prof, you can come in here to explain the issue of breastfeeding. I think it's very, very important for us to be clear where science has given us the facts, and also studies that have been done across populations around the breastfeeding issues. I have seen this issue coming up, especially with a couple of groups where women have been saying that maybe this is the issue. But Prof, I'll hand over that to you to just probably just talk more about the studies and what you know about breastfeeding. Then the test kits and early infant diagnosis. I do agree with the question that how do we then manage this epidemic, especially if indeed the commodities are not there. I think for us as a country, this is where the rubber meets the road, and that is why we must proactively engage our leaders, especially both at the county level and at the national level, to understand the impact of what they call unpredictable supply of commodities and what that does to us as a country. And this is a conversation that has happened. We've been several in parliament. We've been trying to say, please, these are very essential commodities. These are the ones that you must prioritize. So that conversation is moving on a positive note. I think NASCOP is in the room. Currently, we should not be missing some of the commodities I'm hearing, and I would like NASCOP to comment on specific those counties that are missing EID. And somebody says as reagents as late as last week, So I think I'll let NASCOP comment on that. And then also, of course, on test kits. The challenge you got on test kits is, of course, we over-relied for a number of years on donor funding for diagnostic kits. And by the time we began to buy that, I mean, to change the dynamics to begin using the Exchequer funds for the same, it has taken quite a long time to stabilize the supply chain. We know, of course, there's that transition of funding from donor to Exchequer funds. Then we also know there's an issue of COVID-19 that did indeed, even at one point we had the money, and when we tried to put the order, we were actually told that the commodities to be delivered and almost like in an 11-month period. The other challenge we have, even when we have Exchequer fund, this is a challenge that is internal in government. There is an act of parliament that talks about when money is released to the Ministry of Health and when we access the money. So for example, now we are at the end of, we are at the beginning of another financial year. So you have money for commodities. If you access that money, by the best luck, that money comes to you in the month of October. And you begin to do a tender process. It means by the time that tender is done and the commodities are in the country, you're going to another year. And what that means ideally in government is that that money is counted as that it goes to another year, then it's called what you call paid in bill. Now, what is the challenge with that with the HIV supply chain? Is that because these commodities, of course, as you know, have very few manufacturers. So most countries queue for the commodities. So as you queue for the commodity, you also need a legal framework so that it begins then to see that if you always have this commodity you purchase in this year as a pending bill, it means that it affects what you can buy the next year. So we are trying to begin to see, as we transition this thing into Exchequer, how do we then begin to bring everyone on the table to understand the entire supply chain? And only after that, then we are on the same table from the pricing to how long it takes, from who brings what, and then we'll be able to say that in the next couple of years, we are going to have a stable supply chain. For now, I don't want to lie to ourselves that maybe the challenges may continue for a while, of course, not at the level at which we've had them, but also I would want to invite ourselves to our own meetings and begin to ask ourselves, how do we then help even the people at the leadership as we resolve these issues? What can we do differently? What is it possible within what is available? How do we ensure that there's no wastage, especially of drugs? Prof, I was very disappointed, and Rose Fafula was with me when somebody said that because of targets, they want to reach targets, they call a person living with HIV who tells them I've already transferred elsewhere. And so they say, unaweza chukua dawa tu, unaweza tupa. So maybe probably we have not really understood the cost of treatment. And maybe as even the service provider, we have not understood what it means to get that test kit. And now as it moves to our own Exchequer money, it's even more important for us to ask ourselves, do we really understand the cost of that commodity anyone is holding in their hands? Can it even afford to be wasted in any case? So we still have a really big challenge. Then of course the challenge, I must also admit, is the challenge of training. And I know, Prof, you were previously in 2015 advocating that we begin training everyone, not coming back to follow people when they have gone to the facilities, and we come and have selective training for our providers, but basically make sure that every single provider we have on the ground, regardless of when they were trained, they actually have the information on how to treat our clients. So that is the integration we are talking about. How will we integrate that service? How is the current costing model? If we ask ourselves, the current HIV treatment model, even what you're talking about PMCT program, is it a cost-effective model? If we were to be told, sit down and redesign your program. And one of the presentations we did for us many years, Prof, is the one we showed us how the client walks around in a hospital. What does that mean for us to change the model of which we deliver the service? Because you cannot say also we are taking in a model which we have not understood really. If you are to structure our own model, how will it look like? And one of the things that we probably learned the lesson from is COVID-19. COVID-19 response, we never had lessons from anywhere else. So we used our own lessons. We began to think about what shall we do, this disease has come. So maybe it's a time we look at what we are currently doing. There are statements across some of the literature globally that talks about Kenya having the most expensive response in the world. we need to really look at that, where that data came from. I have been trying to get hold of that and ask ourselves, can some of those costs then be probably eliminated, so that then we begin to pump this money now into making sure we also strengthen the supply chain more and more. So those are food for thought. No one has answers right now, but I know we'll have the answers as soon as possible, especially when we all come together. Thank you. And comment on breastfeeding.
Yeah, thank you very much, Ruth, for your responses. Now, the question of breastfeeding, the only time formula feeding used to be better was before ARVs. As soon as we had ARVs, even when we had just a single dose nevirapine for prophylaxis, there was no difference in transmission for breastfed and formula-fed infants. Now, when we have ARV treatment for mothers, and babies getting longer prophylaxis, not a single dose nevirapine, we're talking of prophylaxis for longer. HIV-free survival is better for the breastfed infant and not for the formula-fed infant. So it is true that there are babies who will get infection through breast milk, but they're not many. And when you don't breastfeed, there's a huge increase in the risk of infections, hospitalization, and death, which then rubs out any benefits that you may have had by not breastfeeding the infant. So at the Kenya program, the Kenya recommendations are evidence-based. I know there are people who go around trying to suggest formula will work, but the reality is the data on the ground is that the breastfed infant has better survival, HIV-free survival, than when you do formula feeding. There's even data from a study done in Botswana, randomized trials. Now, do you have other questions? I don't want to dominate the conversation. Any other questions? Dr. Duka, do you want to comment from NASCO?
Actually, I wanted to request we give Dr. Anne Kehara. She's the incoming president of the FIGO, and this is something really exciting.
Yes, Dr. Kehara. Dr. Kehara, please, yes, talk. And I can also see a comment here about the 2018 confidential inquiry that 20% of mothers who died were HIV positive. And the issues were anemia and hemorrhage, eh?
Yes.
Yeah, please go ahead.
Yes, thank you so much. And I want to really first appreciate Ruth Libon. You have really tackled a very important topic. And I want to start from the fundamental basics, where I want us all to focus. The Kenyan populace is generally very youthful. The 10 to 19 cohort, and particularly 10 to 14, increasingly giving us problems with new HIV infections. What does it tell us? They are sexually active. But we continue to still bury our heads in the sand and say, they are not, it's not happening. Ruth, you couldn't have given data that speaks more loudly to all of us. Pregnancy, always look at the back end. What else is it coming with? That's a mother, a childhood mother, getting a pregnancy with a baby who God only knows what is the quality of that life that subsequently comes to being. Is it avertable? And as she showed us the slides, you could see even where the red pockets seemingly are very, very high. And I couldn't help but think, look in tandem, HIV propagation, total fertility rate, contraceptive prevalence rate. So it speaks again, what is our contraceptive uptake and utilization? And are we even moving to the multiple technological products, condom being the easiest and quickest affordable element for all of us in terms of preventing HIV, in terms of preventing even unplanned pregnancies for this age group who principally ought to be in school. I will look at the policy environment, moving from the contraception. What do we say about healthy recreation, responsible parenthood, and what you should be doing as parents in terms of upbringing, providing basic needs? We've heard about Disco Matanga, we've heard about sex for pads from the Boda Boda group. What are we really doing to address prevention, which I think Ruth really articulated, the preventive arm, and putting basic needs. A lot of these girls are becoming sexually active, and particularly with COVID, we saw gender-based violence and the absence of being able to even get basic things like the sanitary pad, food on the table, clean energy sources, water. It's those duties that you have to do for the girl child that even increase their vulnerabilities. Now, moving from there, we need to also look at nutrition. Some of you may think it's far-fetched. A malnourished girl is more vulnerable to disease. So moving even beyond the biology related to sexual contact, anemia in and of itself increases her immune vulnerability to even getting some of these STIs, and including HIV, and including TB, and including malaria. So when she does get pregnant, that even only gets more aggravated by virtue that her immune system has been compromised. You've talked about the issues of how can we rethink financing. That, I think, is really the biggest elephant. And I must say, Ruth, you're looking at it from the context of HIV. Add the contraceptive layer, add what needs to be done in antenatal coverage and the different elements that go with it. I think in Kenya, we really need, as clinicians from whatever discipline we're in, to become the core advocates, the really serious core person. This is what I'm encountering. It's not rocket science. We see it every day. And we have to become the champions that lead in advocacy and advocacy marketing for that patient who really does not have the voice or the knowledge or access to information as she should. The other layer is inform, inform, inform. The public needs to know. The public will then generate a demand for services that are both comprehensive and quality. The other thing is for us to break the silos. For the longest, I think most people who do know me, I've talked about the obstetrician works alone, the pediatrician works alone, the nutritionist works alone. The adolescent is grappling with one clinic to the next. When will we sit at one table and say we are dealing with a common agenda, the primary consumer of our services, and see how we can then collectively pool efforts? It will automatically also bring pulling in of finances, even as we're domesticating our financial access. But that notwithstanding, primary healthcare has to be the center of all that we do. We've got to go to the fundamental basics. How can we advocate for health promotion and preventive strategies primarily? By the time we are seeing them in the health system, in all honesty, you're dealing with disease. Where you're lucky, you may have a bit of risk aversion. Yeah. The other thing I want us to even think through is the issue of data. Ruth, you've done a fantastic job. I couldn't speak even louder than that. But data. But let's be critical. How many of us have got the technology, even just the basic ICT and Excel sheets you can access in the ward and really look and interrogate your data? Therefore, are you even doing clinical audits? Or are you even doing implementation research? And we've got to move as clinicians out of the hospital into communities. The human-centered designing and approaches. Patients are no longer just consumers. They know what they're going through. And unless we move into the communities to really understand what is the context, because it varies. What is in Wajir, what is in Homa Bay, what's in Nairobi, what's in Mombasa will be different. But we have to contextualize even our interventions. And they are even very good because in some cases, they have even come up with their own homegrown solutions. How do we deal with the absence of sanitary pads? Use the eco-friendly model that is in Kisumu, the KMET program. Yeah, so how do we actually begin to apply what patients really know and need into what we provide as healthcare givers. But I think we need to remember also the last bit is the issue and the advantages of having PrEP and PEP. So as we speak to these youth, I think it is critical. Those are issues that must be known to them so that they can actually reduce the HIV burden. And then subsequently, we will have less progeny that is actually HIV positive.
Thank you very much, Dr. Kihara. Very, very well said. I want to throw in the voice of a pediatrician, also a public health specialist in this whole business. The question of adolescents and adolescent sexuality is a common issue around the world. And you have some large data sets that have been analyzed. First of all, the goal of adolescence is to prepare for adult life, to build a human capital, to move towards independent living. And what this data sets show is that deferred sexual debut is probably the single most important intervention or action to achieve transition through school into college and transition into independent living, being able to earn your own livelihood. And adolescents who have sexual debut before 15 years of age almost always enter a trajectory of high sexual risk-taking, being victims of intimate partner violence, and it's just a bad road to go. So I think as we go forward, we must talk about abstinence. We must talk about postponing sexual debut. We must engage parents. You know, a parent is usually taking care of 1 or 2 kids. A teacher would be taking care of maybe 30, 50 children in a class. And we as public health or health professionals, we're worrying about the whole county. So bringing on board parents and in this space is, I think, a very important step in addressing this problem. Ruth Mashar, you talked about meeting a 10-year-old HIV infected, pregnant, or having a baby, and you're talking PMTCT. That's a non-start story. They don't have the cognitive function to actually see through what needs to be done. That 10-year-old needs an adult, their parents, their aunts, their big sister, to work with them every day to actually succeed. So we must work with our communities. We must strengthen families. Yeah. And we must be fully aware that when family life disintegrates, children are exposed to these adverse experiences. They not only translate to this epidemic of HIV, but they actually contribute to the growing epidemic of metabolic disease, depression, you know, many of the chronic illnesses that we see in adulthood. So I agree with you, Anne. We need to get out of the hospital, go to the communities. We highly qualified people. We need to go there and take the knowledge back, take the information back.
Exactly.
You know, and let's challenge ourselves to have an environment that is safe for kids. My other point I want to make is we are in the urban areas. Children are getting sexualized because of the environment they're living in. This business of children living in the house is one room, mom, dad, kids of all ages, is exposing children to sexual activity very early. So it becomes like a normal thing to do. And so you're not surprised that they are coming in then with all the problems related to early sexuality. We can make a difference. You can say in our country, a family cannot live in one room. Children must sleep in a different room from their parents. You don't have to have children sleeping in the same room as their parents, the way colonial Kenya was. were so many years into independence. We should insist on housing that is dignifies people and dignifies the way they live. I could speak on this on many more issues around this. I will not, but I'd like Francis to do that, the head of the lead on PMTCT in the ministry at NASCOP to maybe make an observation. So Dr. Ndoya, please.
Thank you very much, Professor. I hope you can hear me.
Mm.
Okay, thank you very much, Professor, for giving me this opportunity, and the team. I really appreciate the highlights from the team and also the presentation that has been done by Dr. Masha. I think this gives us a reflection of where we are, and key important is that what Dr. Kiara has been able to present are the key actions that we really need to take. What I know is that most of what we really talk, we now need to put it into reality. We really need to move from key of issues around what we present and now make it a practical implementation. For me, the lessons that I've learned is that for PMTCT is a mature project and also a program for long, and we have what it takes to make it achieve the agenda that is there. So for us is that as NASCOP, and also with other partners, we really need to put our minds together as we conclude our framework and as we have our discussions around the way to move this agenda. It will also be important for us to consider some of the key highlights from other members of the society that can also be able to give us a solution and also strategy that works for all of us. So thank you very much, and I take it back to you, Professor.
Thanks, Dr. Breda. I see there are questions about what we're doing in terms of hepatitis B vaccine. I also see the question of why we're using new drug. Let me just say that a new drug on the block is DTG. It is an amazing drug in many ways. It allows for viral suppression very, very quickly, extremely quickly. So the person quickly is less infectious to their sexual partner, or if it's a pregnant woman, to her baby. It is a drug that you take once a day. So it reduces this, it increases the likelihood of adherence. And like when we started off the old drugs, it was like you were eating a cup of getheri every day. Now it is one drug. It comes as part of a combination therapy, and it is well tolerated. It's very well tolerated. So the goals of our programs is to give people treatment that suppresses a virus. When you have viral suppression, you get immune reconstitution. Then you have less problems of infection. When you're virus suppressed, then you're less likely to transmit to others. And when you have a drug you take only one day, you have increased ability to actually adhere. There are emerging issues that I think we're looking at, that people are gaining weight when they're taking their DTG, and I think we may hear more about that as we go forward. But the choice of drugs is always to give the best medication available. So Dr. Dwega, maybe you can comment on the hepatitis B story. Dr. Dwega, can you hear us? The hepatitis B is part of the elimination. The goal is of elimination. Hepatitis B, syphilis, and HIV. So it is part of the program. We already do hepatitis B immunization as part of primary immunizations, right? And I think the discussion is how we can move towards birth immunization at birth. Yes, go ahead, Dr. Drida.
Professor, can you hear me?
Yes, go ahead. We can hear you. We can hear you. So I'm saying that part of it is now moving towards giving hepatitis B vaccine at birth. What is now known is that when you get infection early in life, that's the infection that you're likely to have sustained infection, and which, as you know, is associated with the later life developing hepatoma. So the programs are there, but as you have heard, our challenge is sustainable financing for our programs. I see a question from somebody called Musa, whether we have sexual and reproductive health education in the school curriculum. Ruth Macha, do you want to comment on that? I think NAC is the one that works closely with the Ministry of Education. Masha, Ruth, do you want to answer that?
Thank you very much, Prof. I think this is quite an interesting question that also is a point of reflection, just like I think two previous speakers alluded to the fact that we have a problem, do our solutions really match our problems? So do we have sexual and reproductive health education within school setting? The answer is yes or no. First of all, there's been that whole challenge of what can be put in the curriculum, what cannot be. And what I see lacking is actually the technical expertise that probably is on this call today to drive that conversation of what should actually be taught. Secondly, is that whereas we have progressive Ministry of Education, especially for the last couple of years, where they want to put adequate information, we also meet, of course, resistance from ourselves as parents. We also meet resistance from most of the policymakers. And one of the challenges I did realize is that we probably have been not communicating effectively. So I was recently in a meeting where, of course, a majority of the people in the room being men, no offense for men, and the discussion was about sexuality education. And when you listen to what people think is what the term sexuality means, it totally goes back to sex. And these other components of sexuality, people don't even know about them, and why we are talking about teaching our children. So the same teachers, we are also giving this curriculum to teach, even if we call it age appropriate. And I know now they want to call it family life skills, which is okay. I mean, the name can be called any name. It's also the same teachers belong to the same society we're all in today, where also we've not been able to break the barriers of social norms, even talking to our own children at home. So when they also go to class, they seem to, whatever they are told to teach, also they also have a challenge in communicating to the children. And those are the people we are leaving to our children, and believing that it is school that is going to give us the solution. But yet we know that the schooling and the fact that you have organized group of people, you can imagine you have organized group of people for a couple of years, 8 years, if you have the system going, and then you take them through high school, then you take them through universities, and then you start designing programs to follow them outside now to teach them what you'd already have taught them. So there is a mismatch of what we are speaking today in this forum to what then we speak when we listen to the discussion. That's because we are the same people who are also religious leaders. We're the same people who will be in different settings to what we are saying can be taught and can be taught to our children. So that age appropriate sexual reproductive health discussion in school in setting is probably nothing near what we imagine as a practitioner should be taught. So there's still really a huge deficit in information. There's a lady called Maureen Morenga who shared with us a story that happened 2 weeks ago in a group of adolescents living with HIV, newly diagnosed and pregnant or had a baby. And there's one girl who said for her, I think she's around 10 or 11, she's never had sex. And yet, of course, she's pregnant. And so, of course, the interviewer was asking, so you've never had sex, nobody has come near you? And the girl kept saying, no, no one has come near me. And then eventually she was told what actually sex is. And they tried to describe to her. Then she said, oh, that's the game we play with my brother. And she was saying that the older brother hurts me, and then my smaller one is better, but we play it everywhere. And then it's a game we've been playing for many years. And when she was being asked, she was talking about a game they played from when she was around 6 years old. And I mean, that may look like a far-fetched story, but this is a story of almost 2 weeks ago. So the question then is how old then will you say they're enough to know? Should we wait for that girl for us to be able to explain to her, this is what sex means? This is actually what you were being told about not to do, for her to become pregnant, for her to even be pregnant without even knowing what sex was to her and what was done to her, including that defilement that she was undergoing through the hands of her older brother, who then taught her smaller brother, and the two of them, from when she can remember, have been having sex with her. And this is in a family setting. So the first question, then you all begin to say, where is the mother? Where is this other person? Did the mother was there? Was the father there? So that is the whole, kind of mess that we are in. But I think we need to look at how do we get solution oriented so that we begin to see this is a big challenge, but there are a couple of solutions that we can have. I have had a couple of meetings, especially during this political season, and somebody was asking me why, and I said, you know what? These are the same parliamentarians you're going to bring on the table to begin discussing with me and everybody else. And then they're going to come there and have a discussion that they think that even those commodities we're asking for don't make any sense. They think this is not an issue within their own communities. And that's why we said you cannot wait for a political conversation to go in this country. Then we come back and catch up with politicians. No, when the politicians are campaigning, we'll campaign with them. We'll go to the field and us will be teaching these issues that we currently have so that we're not going to be calling out on them and they think that it's a joke. So different conversations need to happen, including the Ministry of Education, but most importantly, it is the people we are speaking to on this webinar, most of us who actually have sufficient knowledge to be able to advocate. I don't believe there can be any single agency or one individual that will shift this dialogue across the country. We have a group of young people who actually do abstain. How have we motivated abstinence in this country? Have we even put in a program that really appreciate that there's more girls, for example, who are abstinence than the ones who have had sex. So these are a whole dialogue that we can reshape and begin to say that abstinence is also one of the key areas, because sometimes because of what we have been doing for a long time in the response and other places, we always begin to say that of course, not saying we are saying abstinence only, because the one who is being defiled is abstinent, but also those who can abstain are able to be motivated for that abstinence. So yes and no, it is a question, but it's also a question that has multiple answers that we can always look at. What actually are we teaching these children? When are they old enough? When are we going to accept that this dialogue must happen? And why is it that countries that are able to break that barrier of that dialogue, they don't have the same challenges? How have we packaged evidence from across African countries? When I went to Lesotho and not speaking just as a government official, meeting Lesotho, standing up and saying that enough is enough, we are going to give services to all these people. And now you see that they again begin to see the drop of all these infections we're having, and they're having a conversation about abstinence. When will we reach there? When will we start saying that enough is enough? Let's rise up from where we can say that this is an issue that we cannot hide anymore, because the pregnancies are there on our faces, even if we do hide the HIV. So I think it's really an important conversation. Thank you, and over to you.
Thank you very much, Ruth. As we speak, and I invite people, if they're able to dial in, on Monday, 3 o'clock, 2 of our residents will be presenting their experience on a child health experience, where they've been talking to a community about babies of adolescents and the experiences of adolescent moms. And all I can say is that some of the experiences of these young women are a horror story. They are bad. There's terrible stigma to the girl, the stigma to the child, the baby, and the stigma to the parents of the girl who has gotten a baby as a teenager. We're very surprised to find how much sense of shame the fathers of these girls have. And because of that sense of shame, Their actions against their daughters are terrible. The baby of the adolescent girl is not recognized. They don't even benefit from the health insurance that we offer. Like the Linda Mama, the Linda Mama does not, currently as it is structured, does not support the adolescent girl who's pregnant. The Edu Afia insurance for school-going children, high schoolers, will not cover the pregnancy and the baby. So that baby of an adolescent girl is an invisible child, essentially. Yeah. So there are many. I think there are many consequences and conversations that we need to have. Now, the other thing I want to draw attention to is the revised Children's Act. In there, it's very categorical about the business of the importance of not sexualizing children. It calls out health workers not to sexualize children, and there are consequences for doing it. I encourage everybody to sort of read it and understand what it is. The effort, the act looks at life through the eyes of a child, and the effort is to build safety for the child, build a framework of safety for the child, and I hope people will go out and support it and make it work for our kids. I think we are. Agnes, how are we doing in terms of time?
Ruth, can I please make a comment, Prof?
Yes, you may. Go ahead.
Thank you. I appreciate the issue of the revised Child Act, but I think we also have to put it in the context when we think of FGMC and the subsequent motherhood that does immediately follow. So what am I trying to say? Harmful cultural practices must be looked at, and we really need to re-engineer what's the way forward. But I don't want us to leave here without knowing, I think the biggest advocacy message we can give to any child is self-advocacy, self-care, pride in yourself. And I think that message is just not getting across there. Because then you would be able to say, do I really need to have sexual contact very early? No. Do I need to keep myself in school? Yes, I will get employment that is significant and possibly have even the safety nets into my yonder years. But I think we really need to begin to bring the message of prevention and prevention. And unfortunately, there will be those that will pass through the net, whether we like it or not. What happens? We are talking about the girls who eventually get pregnant and have children. What of the other cohort of women who then go down the other road of unsafe abortions? What are the policy regulations and how easy is it to get into pregnancy crisis centers, to get adoption as an alternative, but above all, even getting to screen for HIV amongst that group? Because I think we're really having a lot of missed gaps when you really broaden your mind into thinking the context that is around different girls' situations.
And Dr. Kehara, it's good you highlight that. Actually, the act is very detailed on so many things, including adoption and the options, taking into account protecting young children from child trafficking. It's very, very detailed. I think we should look at it and engage with it. And as we are all saying, it starts at the family, it starts at the community, it starts with the norms that we normalize. I listened to the PS in the Ministry of Education, and she was very clear that we need to have, what we teach should not normalize, it should not normalize early sexual debut for teenagers. So what we teach, so even how you package your health education material for schools must help to normalize what is healthy living, what will afford these youngsters a better life. We must remember that adolescents copy each other, peer pressure. My last observation is to Dr. Masha. I hope you're still with us. is the document called Comprehensive Sexual Education that is attributed to WHO has components in there that actually there were things that make people angry and reject the whole document totally. I'll not go into the details of what it is. I'll invite people to go and look it up and read it and ask themselves whether that I get the impression that that document was really meant for adults, not for youngsters. I'd like to stop here. I think we have had a healthy discussion. I will now invite the colleagues to tell us about the next webinar. And Dr. Masha, thank you very much. Do you have a last word for us?
Thank you, Prof. Really, thank you, KNH, for inviting me on this call. But let me just wind up by saying, even the last point you've raised on what WHO has given us a guidance. I think we as a country, and that's the point I made about what we've been able to do with COVID-19 response, we have the responsibility to say we are technocrats, we know our cultures, we know our people, we know what can be age appropriate, and we can know how to deliver a proper curriculum that makes sure that our children are not lost, at the same time being within in a space that we know that what we're doing is the right thing. So for me, I think that we should not shy away to say that this is what we should do differently, so that other countries can follow us. And you've seen consistently some countries going and creating their own things, and the world follows them. So culture is important, context is important, and we can take these global things and shift them in the way we do business. Thank you, and over to you, Asante-san.
So thank you very much. So now let us invite the KNH team to let us know about our next seminar. Thank you very much. We've had very good attendance. I see we are at about 700 people. Thank you very much. And thank you, Ruth, for a very excellent presentation. And thank you for everyone who asked questions and contributed to this conversation. Yeah, so Agnes, please.
Yes, thank you very much, Prof, for that session, for chairing us very well. We really thank you, our presenters. Dr. Masha, thank you for making the time to give us that very elaborate presentation. We really do appreciate. Dr. Kihara, thank you for being with us. Dr. Kinuthia, thank you very much, all of you, for your time here, even from NASCOP. Thank you so much for your time. And we appreciate also our attendees for staying with us on this World Hepatitis Day. I'm being reminded, yes, this is the World Hepatitis Day, and we've been able to talk about the elimination of the mother-to-child transmission, the HIV, syphilis, and hepatitis B, and we really do appreciate that. Thank you all. We welcome you for our next series. We will continue our pediatric series in the coming Tuesday. We welcome you for that. Do have a lovely evening. Thank you all.
Thank you.
Okay, thank you, everybody, and Kwaheri.
Thank you.
Yeah.